All right, thanks, Marcus. I will caveat this by saying that I'm giving this for Dr. Saji, who's not able to be with us, and he is really passionate about this. And so I will hopefully impart some of his wisdom to you guys. So what's the scope of this problem, right? Well, we all see infections, whether you take care of arthroplasties with PGIs or fracture work. But if you think about it, it's really actually hard to know the true incidence of infection in what we do. And there's a variety of reasons for that, one of which is this concept of culture-negative fracture-related infection, right? You got somebody you think is infected, nothing grows out. And how does that change how you treat it? We also know that the CDC describes surgical site infections a little bit differently than what we typically think about with FRIs. And cultures aren't a gold standard. We claim they're the gold standard, but they're not if they're not always 100% sensitive and specific. So we know they're not very good, and that creates more issues for us. And we know that our hosts aren't getting any healthier, so the incidence of fracture-related infections and PGIs is going to continue to increase. We've got older folks who are less healthy, and we have an obesity epidemic in this country. And this is what you're trying to avoid, having this patient roll back into your office with metal sticking out through their leg. All right, so really up until a few years ago, we didn't have a consensus definition for what an FRI even was, right? So having a consensus definition where we're all on the same page helps identify the true burden of the disease process, which improves and standardizes care, leads to better research and outcomes. In theory, should lower antibiotic resistance because we know what we're treating if we're more likely to pick it up, the correct bugs, less treatment failures, and then hopefully springboard for future technology to make our lives easier, because this is hard and frustrating for all of us. So in 2018, just 5 years ago, a bunch of trauma surgeons and experts got together and formed a working group and put on their input. And so we now have agreement on what defines a fracture-related infection. You can see this blown up here, right? But the emphasis is on two things that maybe we didn't emphasize before. One is pathology. So who here does arthroplasty on a regular basis? Do any of you not look at cells per high power field when you stage somebody? Right? You're always going to send some tissue to the lab and see if there's any inflammation, and if it's still there, you're going to probably put a new spacer, and then you're going to put in a new joint later if you're dealing with an infection. Well, in fracture work, we don't really do that, right? That's kind of a foreign concept. We would take some tissue, maybe 1 or 2 samples, see what grows out, and we oftentimes weren't sending enough tissue to get good culture results, right? So a single culture in the new definition doesn't prove that you're dealing with an FRI, right? You want more information, and pathology is very important in this whole process. All right, so again, think like a joint surgeon, right? I'm a fracture surgeon, I don't replace joints, but joint surgeons, they look at cells per high power field. And so you can look at the tissue and see what's going on, and it helps identify whether there's a true fracture-related infection you're dealing with or if it's something else that's not infected. Okay, so then why even culture? Well, cultures help guide therapy, right? Okay, yes, you have histopathologic evidence of an infection, but you don't know what to treat, right? So cultures have become important. And this is just some slides from a recent study, but what you'll see is that, in this particular subset, 14% were culture negative, right? Your infectious disease guy does not want to know that he does not know what he's treating, because they're going to get broad spectrums, and you don't know what the outcome's going to be for that patient. So if you have an infection, you want to know what you're going to treat. And we know from that particular study that most of the time they're only taking a couple samples, right? Most were 1, 2, or 3, with rarely 4, 5, 6, or 7 samples, right? And only in this study, only 7% had PathSent, right? So again, the emphasis moving forward is get some pathology, get more tissue, get good tissue to increase the likelihood that you're going to get a bug growing out that will help guide therapy. All right? So this concept of culture-negative FRI, again, you've got patients with non-microbial evidence of infection. So they've got a draining sinus. You know they're infected. They've got pus. You know they're infected, right? You get path, and it shows acute inflammation. You know they're infected, but you don't have any organisms. Like, it's the most frustrating thing to deal with, especially if you're the infectious disease guy or the surgeon taking care of the patient, all right? And it's the inability to recover an organism that we know, and these are the results, right? So they've been on previous therapy, right? How many of us have had patients put on antibiotics by their primary care doctor, right? Or by someone else in your office because they called the after-hours line on a Saturday night, say my leg's a little red, so the surgeon calls in some antibiotics, or the mid-level calls in some antibiotics. They're on something, right? That decreases the yield when you go to take them to surgery, all right? Inadequate use of available microbiological methods. We'll get into that shortly. And again, there's previously unrecognized causes that are not readily identified through currently used techniques. All right, and again, false positives, which come up pretty often. So optimizing your available methods. The number of cultures we know, the more the better. So the recommendation now at our institution is no less than 5 samples. And we'll talk about that a little better, where you get the tissue from. We know that sending the tissue in blood culture bottles actually leads to better results. They're easily and they're readily available. Sonication is a technique that you'll maybe have access to if you want to. Perhaps you've got a recalcitrant non-union nose infected, you've never got stuff in the past, you're taking out hardware. You can sonicate that hardware and increase the yield for stuff that's growing, in biofilm on those implants. Then a no-touch technique to help prevent false positives. You can imagine if you've done this big exposure through a pussed-out wound, and then you take that same raw injure to take some tissue, well, you may get some contaminants from the skin that you think are what's causing it, and you're going to end up treating the wrong bacteria. So using clean instruments when you get the tissue you want from deep in the wound, not from the sinus tract or the skin. All right, and then again, your pathologist is in the basement. They work in the same place, so use them. And again, previous use of antibiotics makes it harder to control, but again, getting away from inappropriate use and good antibiotic stewardship is important. And then again, new molecular diagnostic tests are on the horizon, and we'll get into that a little bit later, but this is the future of infection control in our line of work, right, is using things like PCR, metagenomics to figure out, what bacterial DNA, are in a wound bed. The issue right now is that you get so much DNA that you don't actually know what to do with it, and you get host DNA, which complicates matters as well. Okay, so as far as how many samples, how many culture media, we know that the more the better. So this is just a slide from our institution. As long as you've got some sort of good algorithm, whether you're doing PJIs, fracture work, et cetera, it helps to have a system in place. So we get 5 samples of tissue. If there's frank fluid, we'll send that as well. And then we send the synovial fluid differently if we're doing an aspiration before you open something else up. That's usually for PJI, not for fracture infections. We just know you want to get good amount of tissue from certain, so we get it from the implant bone interface and from tissues directly around the fracture-related infection. We're not just taking random tissue. We're not sending the sinus tract because it's low yield. And then we know that using blood culture bottles improves the sensitivity. You can see in this one study, 92% versus 60. That's a big jump, right? That's a big jump as far as making sure you're going to grow something out that's truly in there causing an infection. And it takes less time to speciate and to grow out. So you get your results sooner, so you can tailor therapy a little bit better. So, for example, you can turn off those big guns and put on something more focused on the actual organism that you're going to try to treat. Again, if you're going to sonicate, it's usually for when you're trying to get stuff off of implants. You're not really going to send bone and sonicate it. But again, if you're yanking out a joint or you're yanking out a plate that's got tissue on it, you can sonicate that and then culture that, and you can get pretty good return of decent data that'll help guide therapy. This is actually a slide. This is in all of our ORs where we work at UC, so that everybody knows how we do it. So we're getting tissue from the fracture, we're getting bone, we're getting periosteum, and we're using sterile instruments. So the stuff that we are using for the approach and the exposure and the dissection is not the instruments we're using to take the tissue. We have a separate tray for that so that we don't end up with false positive results, and we're getting good data back. You want good data for your pathologist, and we want good data for your infectious disease guys. Unfortunately, we know that previous use of antibiotics will lead to lower yield of good data. So if you've got to take someone back, it's ideal to try to hold antibiotics if they've been on them for at least 2 weeks. And that sometimes isn't possible. You got a patient that's on antibiotics and they come to the ER pussed out and septic, you're not going to wait 2 weeks, right? Just know you're going to be less likely to get good data, and as you can see through these numbers here. On the terms of your pathology, you're looking for visible microorganisms in the deep tissue, which is confirmatory, but also the number of PMNs. We know that more than 5 is essentially consistent with infection, with a number of studies with a sensitivity and specificity of 100%. So if you get your path and it shows multiple cells, they got an acute inflammation and it's infected. So this is a case example. This is a guy, not a case of mine, but a patient that came through UC a long time ago. And they had a closed femoral neck, and they got this fixation, and then they disappeared for a long time, like 9 years. All right? This is how they return. They've been dealing with this sinus tract that's been put on antibiotics off and on by other providers for the last 9 or 10 years, but they're finally in your office because they're just sick of dealing with it. And you can see a sinus tract. So, is this patient infected? Yes, they're infected. You're going to treat them for their infection. So you get an x-ray, and that's what it looks like. You're like, that sucks. But if you didn't see the sinus tract and you got this x-ray, would you say it's definitely infected? Could be 10-year-old AVN that just fell apart, right? It's a femoral neck. So the sinus tract is confirmatory, right? Without that knowledge, you really wouldn't know which one it is. But the sinus tract tells you it's fracture infection. You're going to treat this like an infection, all right? The surgical information helps as far as determining what's going to grow and what you're going to treat. So in this particular example, you're going to want to take bone, you want to take synovium, adjacent muscle directly next to the fracture that might also help improve your yield. And you're going to want to take 5 or 6 or 7 or 8 or as many samples as you want to send. And this is what they end up getting here. This is an older case where, you know what, they didn't take a bunch of samples. We started our protocol about 2020. So they did all this work and only sent a couple samples. And unfortunately, this is what happens. So you don't tell the pathologist what you want to look for. So they look at the sinus tract, which was useless, and just tell you that there's acute and chronic inflammation. That's not very helpful. And then you send your 4 OR specimens, but this patient's been on antibiotics off and on. You don't get specific tissue that you might, so this is just the reamings here in this example, but nothing grows out. So this patient ends up requiring broad spectrum antibiotics for 6 weeks, as opposed to something that might be more tailored. We can do better. So again, like I said, get more tissue, get more cultures, sonicate if needed, and try to be sterile with your instruments when you get this stuff. And to have a team effort, right? So if you were in a hospital where you're doing a decent amount of infection work, try to know your ID colleagues who are going to help you. Try to know your lab and path folks. All right, this is the team at UC. This is Dr. Saji here, but he's put together a team with a plastic surgeon and a PhD in the lab and an infectious disease guy who only cares about FRIs and PJIs, and he collaborates with these people on all these infections. And our results seem to be doing much better. So that patient, again, got therapy. Fortunately, he heals up, and he loves his shoe lift because he's not getting any surgery anytime soon to put any metal in his body. All right? One other concept that most people don't appreciate is, does it matter where you live? Okay? And it does. Understand your local antibiogram. That's available at most institutions, and it helps you know what the common organisms are and what they're susceptible to. If you're in an institution or a place where, MRSA has a resistance to Bactrim of like 95%, well, and you probably don't start people on Bactrim for cellulitis because it's probably not going to work, and it's just going to breed more resistance. So know what's available in your area, and then appreciate that there are seasonal and regional variations in infections. And this is a paper put out now about 10 years ago that kind of demonstrated that. And a number of faculty here were on this paper and contributed to this study, which was pretty important. All right? Over 5,000 patients, and they saw differences in infections. So in the spring, 10%. Right? Summer, 8%. So differences here, and that was significant. And then you look at different regions. You see that higher incidence in the plains and the south. The patients must just be more unhealthy. Well, maybe not, right? I mean, we have unhealthy people all over this country, so it's hard to say, well, just because they're unhealthy in the south, that's why they're having more infections. And then if you were to break it down by individual places, so just pulling up the Northeast, for example, differences in one portion of the country based off season. And oh, by the way, the bugs are different by the season. So this is all good information to have based off where you are. And that kind of makes you go, wow, kind of shocking. You wouldn't expect it, but that's what the data shows. So what's on the horizon? So hopefully in the next 5 to 10 years, we'll be able to just take a bunch of stuff and send it to the lab, and they're going to do PCR and genomics, and they're going to spit out some complex algorithm of data, and they're going to tell you what's causing the infection, and they're going to say what to treat with. Hopefully that's what comes sooner rather than later, because it'll make our lives a lot easier. The problem now is that, one, it's expensive. It's user dependent, so you've got to have people who know what they're doing with this technology in your facility. And then also, you're getting a lot of data, right? So you have to figure out, well, what's actually causing the infection, what's just incidental findings, and what's actually the DNA of the person, right? Because it just, gets gobbled up and then gets whatever they do, and I don't know what they call that stuff. All right. Again, we have a number of studies starting with next-gen sequencing showing that it's beneficial, right, for identifying organisms for fracture-related infection, PJIs, right? And so this is a recent paper that talks about that. And in that study, they found that next-gen sequencing picked up the microbiology in 91% of the 56 culture-negative PGI cases, right? So when nothing's grown out, they're getting data that shows there are bacteria. So moving forward, this will hopefully help us identify and treat our patients correctly. Thanks.